Hello, my name is David Armstrong, and I'm the Director of the Health Workforce Tactical Assistance Center, and welcome to our event today. Today's event is entitled Vertical Integration Among Community Health Centers, Impacts on Staffing and Patient Outcomes. Let me go ahead and introduce today's speaker. Eric Law is an Assistant Research Professor at the Fitzhugh Mullan Institute for Health Workforce Equity, Department of Health Policy and Management at the Milken Institute School of Public Health, and of course, the George Washington University. Eric, welcome.
Thank you, David. Hello, everyone. Welcome to this webinar. So today I will be talking about one of our recent major work around on community health centers that's looking at the impact of vertical integration among federally funded community health centers and their impact on staffing and patient outcomes. So here is the our research team. I'm working with Dr. Muqtadari and Dr. Dor, both of my senior advisors here at the Department of Public Policy. I'm sorry, Department of Health Policy and Management, and also two very talented PhD student, Mr. Park and Mr. Chang. So a little bit of motivation on why we're looking at vertical integration between community health centers and hospitals. So this is a 2021 paper that's looked at the the impact of physician groups and mostly primary care physician groups vertically integrated ways hospital system, and they find that in general, this is an economist written paper, so they're generally looking at the price impact and they're moving the test locations of the imaging and other lab services towards hospital sites. So, but as a general background, we're looking at okay, there's a quick pickup, generally pretty quick pickup in the recent period of primary care physician integrated ways, larger health systems, and we're thinking about, did this happen with CHCs? And sort of, if you think about this, there's the potential benefits of vertically integrating CHCs into the delivery network of hospital systems, right? So there's streamlined care coordination and better access to specialty care for the underserved population, as well as potentially reducing the emergency room utilization and hospitalization if you can link them to primary care. And also a little bit on the financial side, right? So Medicaid and Medicare has preferable reimbursement for the CHCs, like they have like a floor rate, that's the Medicare rate. So if the Medicaid MCO pays below that rate, state has to pick up the tab, right? So there's some sort of flooring for the reimbursement. And also, like, there are Section 330 grants from HRSA to support the operation of CHCs. So, but there are also some constraints, right? Section 330 grants require the CHCs to be patient-directed on the board, as well as like different states have corporate practice medicine, like prohibiting certain organizations or all organizations from employing physicians directly. So here's an example I'm talking about, right? So I'm not sure how many of you know this. It's at Boston Medical Center. They have the Boston Health Net, which is Boston Medical Center, with a network of community health centers joining force to provide a better access to, primary care, specialty care, as well as dental services through the Boston network. This is sort of the motivating example that why we're looking for more of those potential collaborations and affiliations or vertical integration in a loose term between the community health centers and hospital systems. So here are 5 research questions that we're trying to address through this research. This is has been going on for a couple of years. So we started out with the first 2 research questions, and in the second year we added the first 3 questions, and then added the last 2 questions because they have different, we're facing different challenges at different steps while conducting this research. So basically, the first goal is trying to identify different types of integration mechanism and how many of them are actually integrated nowadays, or at the most recent of our data when we conduct the research. And also, what's a trend of vertical integration among CHCs over time, and is there any impact on the workforce configuration as well as the utilization quality outcomes of patients seen at CHCs? So, first, among the while we're talking about different ways of vertical integration, they could be direct employment of CHC healthcare providers, or This is similarly to very similar to like direct ownership of CHCs in the earlier days if a health system like established those CHCs to begin with, or affiliation with hospital systems, and could be like they just reported affiliation, and then there's control of influence over CHC board of directors. That's like one of the more common things that we see here, and also, they can integrate CHC in alternative payment models, and here we're only assessing like in ACOs and most Medicare ACOs. So the first challenging we're facing in our methods is like in how to identify health centers in different data sources. From one of our prior work, we already collected the tax identification or federal employment identification numbers for CHCs that's matched with their Section 330 grant reporting in the UDS data. And here, another challenge is that most of those integration data were linked with MPIs, and we will need the MPI. We also need the MPIs to identify the CHC services in Medicaid claims. So the first thing we're doing is identify the MPIs, right? So we started out with a HRSA list, and HRSA list actually from end of 2022, they provided somewhere around 5,000 MPIs, and they're including some arrows there. Here and there. And the issue there is like many CHC did not report a single MPI. And even for those reporting, they're missing quite a few. So we go back to our UDS site list from 2014 through 2021, and we matched with a cumulative version of MPPS. Because MPPS actually, only reports the most recent version of the MPI record. We have to use a cumulative version from 2007 through 2022. We did additional matches, including CHC name, age, address, site name, address, and center name address, all kinds of mutations there. And we found over 21,000 additional matches. However, there's issues there, right? So a lot of CHCs operates different sites at senior living, assisted living facilities. So a lot of times there are mismatching between nursing homes and that kind of CHC site on the nursing home. So we went through a manual cleaning with a team, of a team of 3 basically, and we finally confirmed 17,400. 17.3 CHC affiliated MPIs for 1,381 CHCs. We cannot find any MPIs for 21 of them, and most of them were earlier CHCs that's either closed or are merged into other CHCs. So to identify the second challenge is after we identify all the CHCs, how do we identify the integration, right? So the integration are identified through 4 different sources. The first one is using the IRS Form 990. Not sure how many of you are familiar with that. It is the nonprofit organization tax return that's filed in each fiscal year to the IRS, and it's publicly available from 2011 onward if they're filing in an electronic form. So what we did was we searched the Schedule R. The Schedule R reports the related organizations, what they call, and it's generally the organization with common control or being sister and sibling organizations that have a common parents, or their direct owner organization or direct subsidiary organization, those kind of things. And we look for there, and we match with a known list of employee identification or tax identification numbers for hospital systems, and see if there are any organization that's owning the hospitals, the CHCs, or being a sibling of the CHC organizations. And that's the number one way we're identifying, identify hospital system ownership of CHCs. The second one is using the our compendium file, and they're reporting the affiliation with health system. We went through from MPIs to, the PICOs, which is Medicare enrollment system for providers, to get the PAC ID number, because that's what's used in our compendium. And we're using 2016 and 2018 version of the compendium. At the time of study, the 2020 version was not released yet. And then the last one, the shared board members. We also go back to the Form 990 in the primary schedule, or in the form. They have reported the key employees and board of directors of all the nonprofit organizations, and we're doing a matching of CHC board of directors against the health system in the same state, in the same vicinity, um, their board of directors as well as the key employees trying to figure out is there any overlap there. We only consider that's a matching if there are more than three members being matched. So and the last one is this is CHC participation in ACO with hospitals. So we basically go through the Medicare ACO files by name, and we do a name match with hospitals as well as name match with CHCs to figure out the affiliation. So here are some results for the first question. Like how many of them are actually integrated, right? So the vast majority of CHCs were not vertically integrated with in any way, shape, or form with hospital systems, but a small fraction, roughly, less than 20% were. So there were 17 actually ownership, which are established by hospital systems, basically, or acquired by hospital system over the years. And affiliation, that's reporting 91 of them. And there's 131 CHCs are sharing more than 3 board members with a hospital system nearby, as well as 36 used same ACO that led by a hospital. So you will see that the total number doesn't add up to 35 because there's a lot of overlapping, and different channels might identify the same CHC as integrated through different channels. So, but in total, we have 235 were considered as integrated by the end of 2021. So here is some numbers of the integration trend over time. So you will see that the affiliation is a little bit stable because we only use 2 versions of that. So all the data prior to 2018, we're using the 2016 version, and after that, we're using 2018 version of our compendium to identify that portion of the integration. But you'll see that quite a few increase in board membership as well as the ACO participation. That's the primary source of the growth of the integration over time. That's the green and yellow part of it. So here we take a look at by the 2020. We'll take a look at that number by 2021 using the 2021 UDS data here, and we tabulated essentially. Is there a difference? What's the difference in the workforce configuration in the integrated versus non-integrated CHC? What we figured is that if you can see here in the first few rows in the medical personnel, there tends to be way more medical personnel FTE in the integrated CHCs. It tends to be larger and potentially better staffed, right? But however, that kind of thing doesn't really carry over too much into the enabling service personnel. You will see that here and there, some of them are, better in terms of, you have maybe a little bit better interpreter and eligibility assistance and also transportation assistance, that kind of stuff, but not everywhere. And there's pretty large variance in both integrated and non-integrated and groups. So in general, there are some difference, and most likely they're in the medical service personnel category, that's being larger. So, and now the next one, we're taking a look at the utilization outcomes. Here we're using the TMSIS data. TMSIS data is a newer version of the old MAX data. It's standardized across state, but it still has a lot of issues where we need to use them. And for instance, the inpatient file is no longer a hospitalization file. We have to, go over the inpatient claims, trying to link different inpatient claims together to get a hospitalization stay. And same thing for the emergency room utilization, as well as some E&M services visits that for the and then for the CHC patients, right? So, and also quality outcome, we're using the ARC PQI from basically all of them, and we're looking at any ambulatory care sensitive conditions, hospitalization. So basically, we have to identify the hospitalization, go back to identify whether that hospitalization is actually due to ambulatory care sensitive conditions. And this we're using the staffing variables from 2000, the matching year of UDS, trying to do run some regression to see if there's any residual impact of CHC on the utilization outcome variables. So, and before we can proceed to the analysis, we have to do some patient attribution. What we're doing here is that we attribute the patient to a CHC if we found at least one outpatient evaluation management claim from a CHC MPI, either as a billing MPI or as a servicing MPI. Here, I have to explain a little bit because in all likelihood, when the CHC actually bills for their claims, right? So they will have the individual provider as the servicing MPI, but their own organization MPI as the billing MPI. However, because there's some data quality issues in TMSs, sometimes the servicing MPI is actually an organizational MPI, and the billing MPI might be flipped. So to account for those like potential issues, we basically say, okay, if any of the claim have any CHC MPI as a billing or servicing MPI, you're in for that CHC. And a sort of issue with this approach is that the individual patient might be attributed to more than one CHCs. If, like, for instance, if they're in New York and they have access to multiple CHCs in close vicinity, right? And so we can, but this is also very similar to how uniform data, the UDS data, uniform data system, and it generates quality and utilization outcome for CHCs because they only know who is visiting. Like those are CHC reported, right? CHC only know who is visiting themselves. They cannot be deduplicated across CHCs. So we basically ran a difference in difference analysis at CHC level on the changes of the on the integration status. So here's some basic outcomes. We're looking at the percent of patients with any hospitalization. That's about 6% or 7%, and over 33% of the population that CHC has some sort of emergency room visit, and also don't freak out at the specialist visit because this is like accounting for all the specialists. That's just not general internal medicine, not MPPAs that's reporting at primary care, not family medicine, not pediatrician, general pediatrician, right? So that's like everything. So and then we look at ambulatory care sensitive conditions. So if we're just looking at the overall, that's about 3% of them have some sort of ambulatory care sensitive condition, hospitalization. And here are some regression results. Basically, we're controlling for I should first say that we're controlling for the staffing composition at the CHC. This is all the physician FTE scale by the number of patients per patient, as well as here is a control for the number of Medicaid bed recipients from the TMSS data. I have to admit that there's roughly 80% of our observations, CHC level observations, have very similar number of CHCs. I'm sorry, CHC reported UDS reported Medicaid recipients compared to what we captured in the TMSs, but there are some small number of them are quite off, but we kind of, this is the full results that's including those quote unquote outliers. We later did some investigation on those outlier observations, and we didn't really see any irregularity in terms of their Medicaid claims, so we sort of leave them in, but we did a robustness analysis excluding them, and results are generally very similar. So without further ado, we look at the vertical integration impact on hospital per 1,000 hospitalization per 1,000 patients, and we didn't see it's slightly lower the integrated CHCs, but it's not statistically significant because the standard error is very large. But on the flip side, there's like benefits with ER visits is actually a little bit higher among the integrated CHCs for the and then there's no real difference. It's slightly lower, but not significant difference in terms of percent of beneficiaries with any specialist visit. And not really surprising in a sense is that none of the FTEs actually makes a difference in terms of because we're tracking their outcome generally outside of CHC. So the CHC physician, their workforce configuration doesn't really show much of impact in terms of overall utilization. here is the impact on the quality of care, and there we're using any PQI hospitalization per 1,000 beneficiaries. And if you see that here, some moderate evidence, I would say it's the integrated CHC shows about like 0.7 lower PQI hospitalization, which is about roughly like 1/3, which is pretty huge difference, but it's also large standard errors. So, and also similarly, none of the FTE stuffing configuration at the CHC level really affected the PQI here. So a little bit, just recap a little bit about the findings. Integrated CHCs tends to be larger and better staffed, and seemingly there's lower hospitalization rates for ambulatory care sensitive condition among integrated CHC patients, but there's also higher ER rates among the integrated CHC patients. That one we have a little bit of theory, but it's hard to do the investigation at the way that I currently extract the data. We're thinking that it may be because vertically integrated CHCs might have a lot of referral from the hospital when the patient shows up at the ER, right? So that could be one of the reasons why it's higher, but at this stage we don't have any proof for that, and we didn't find any statistical significant results impact overall hospitalization rates and specialist visit. It's kind of mixed evidence on the integration, so proceed with caution. That's my overall observation on the sort of the why CHCs or on the overall impact of CHCs vertical integration with hospital systems. And also a little bit of limitation that this attribution method coupled with we have to aggregate the data back to the CHC level for analysis kind of masks the causal inference possibility, because in the ideal scenario, you would actually look at the exposure when they first get into CHCs and track the outcome after they leave the CHCs. But given the sheer size of data and scope of work, we didn't opt to do that. And there's, as I said, alluded previously, there's some discrepancies in the UDS reported Medicaid patient number as the TMSIS identified Medicaid patients for those CHCs. It could be due to some Section 330 grants reporting issue, because not when they are Section 330 grantees, not all the scope of the parent organization is actually part of the CHC, the Section 330 federally qualified health centers, right? So that could be one of the issues we need to address in the future, and also more refined utilization and quality outcomes can be developed to better analyze the impact of those CHCs. Because from my prior work on vertical integration between cardiologists and hospital systems, even if there's any impact of integration, generally speaking, it's pretty small in terms of the patient outcome. It's more in the practice patterns and things like that. Physicians moving their testing from their own practice to hospital systems, things like that. So we're yet to see those things in the CHC world. So any questions?
Thank you, Eric. Just a reminder to those of you in our audience, you may ask questions using the Q&A panel on your screen. So by all means, fire away. With that said, I have a few questions to get us started. I was actually really interested to see you use, I guess, the TMIS data. I don't know if I'm pronouncing that correct, if that's the right acronym for it. The new Medicaid data sets to replace it for the old Medicaid Extract Max data. Yeah. How ready do you think this new data is for workforce research? That is, what are the primary challenges in using the TMIS data to analyze the workforce of community health centers?
That's actually a good question, because we actually encountered quite a few challenges using the TMSIS data. First is, the cost part is let's set aside that part, because it's around, $60,000 per year to access the data, and the CMS is moving away from the physical data delivery, which is going to be creating additional barriers for, junior analysts. But in terms of TMSIS itself, it has quite different levels of data quality across different states and across different years. For instance, there was one state, I think it's Missouri, in the first year, actually they accidentally flipped all their MPI field with another field, right? So there's like um, multi billions of number of lines you need to look for, and there's like those kind of very nitty-gritty detail challenges that you have to be really aware of those data quality issues. Like for the Missouri part, I think I remember, if I remember correctly, Missouri actually put their servicing MPI in the servicing ID field and putting the servicing ID in the servicing MPI field. Unless you really look into the data, you don't really know that. And the second part is that different states may have different level of missingness in terms of their servicing MPI. If you're looking for workforce analysis, that's the most important part, right? And we also noticed that like CHC claims, supposedly they are submitting the institutional claims, right? I'm not going to too much of that. Unlike general practice, you're submitting professional claims, you're submitting institutional claims, and for some reason, certain states have an even higher rate of messing up their the submitted claim for the institutional claims. That we have a theory. It's just that in the documentation they talk about like attending MPI, which is we see quite a few in the Medicare claims, but the field is entirely missing from TMs. We don't really know what kind of things they're doing with that, but that's like a big issue there. So for the CHC. So, but luckily for this exact study, what we kind of jumped over that by using directly organization MPI. We're not like, we're not looking at the workforce using the TMs yet. So I would say TMs there's quite a few challenges facing the workforce researchers, especially those two, like, the completeness of MPI and idiosyncrasy of states might have with their MPI numbers. Yeah.
Hey, thank you, Eric. Yeah, you really did utilize a lot of data sets to get at these findings. So that's very impressive from my mind. And of course, this study really does focus on the ultimate safety net providers, right? Community health centers. And so I guess how can this research method that you're using here be used to leverage to provide better evidence on the impact of community health centers services for Medicaid patients?
Great question, right? So this thing is kind of almost directly replicable, right? So once we get the list of MPIs, we can, go out for the NQF or, what other quality forums that they have established a lot of different, quality metrics that can be generated using claims data, and we can directly use those methods to aggregate the CHC patients from the quality metrics generated at the patient level and directly aggregate them up to the CHC level using the TMSS claim data, where you can use different methods attributing patients to the CHC and providing way more granular or quality outcomes, because that is looking for their measuring their overall utilization qualities throughout the entire journey with the healthcare system, instead of just like focusing on one part of what happened inside the CHC. That's what the UDS reporting for most part.
Okay, well, sticking to this theme of like underserved populations, et cetera. Larger and more sophisticated CHCs appear to be better positioned for vertical integration. Could this advantage lead to disparities in the services provided to underserved populations?
In theory, yes, right? But based on what we find so far, we yet to see even like the potential benefits of vertical integration actually being realized from the data side, right? So in theory, yes. And my colleague Sarah Rosenbaum actually said quite a few years back to me is that the more sophisticated CHCs, they are working in an entire different world compared to those like less resource CHCs, and we see that kind of showing up here. They probably have better access to um like resources, capitals, as well as other kind of healthcare resources, but maybe they're also dealing with more challenging population. That's an issue. Is like, if you better resources, you're dealing with more challenging population, and we yet to see that the vertical integration actually is showing up with major differences in any of those patient outcomes we looked at in this study. So in theory, yes, but I'm not too worried about that at the moment. Yeah.
Okay, okay, that's fair. That's fair. Vertical integration itself. You showed a trend in one of your earlier slides. I believe it was
Mhm.
between like 14 and 16 or 17.
Yeah.
It was going up a little bit. I know then in another slide when you showed integration trend over time, like the types of integrations,
Mhm.
it seemed to taper off a little bit there. That is, you
That's
see an
true.
upward trend and then it levels off. Do you have any theory on this? Do you think it might pick up again or?
Um, this is kind of very interesting because we see this kind of tapering off not only um, in terms of like in CHC or primary care integration, but also in like those traditionally more likely to integrate kind of specialty areas like cardiologists and radiology. So one of the things is that I think around 2017 and 18, some poor part of that, if I remember correctly, CMS finally realized they made a big mistake that they kind of selectively reimburse certain services much higher in the hospital environment, and that provides additional kind of incentives for those for hospitals to acquire CHCs as well as other primary care practices. But starting 2018, I think the newly acquired sites can no longer be classified as hospitals. So that kind of put like a sort of stopgap for their incentives to get more. Like the previous one were grandfathered in. I don't know what they're going to do with it, but they cannot no longer put new one in. So maybe that's sort of the reason why there's no new impetus for them to acquiring more over after 2017, 18-ish, that's a period. Yeah.
Okay, yeah, I was kind of curious about that. What might be going on?
But it might be, picking up if CMS, like, I think the CMS start to make those differential payment back in 2008 or 9. We see a huge jump up of cardiologists and radiologists. That's when they start to do those differential reimbursement, and it's kind of that sort of a thing. And now they stop those things, but if they, make those happen again, who knows? Yeah.
Mhm. Yeah, and just a reminder for those of you in the audience, you may ask the Q&A panel to ask questions. You actually hit on this in your findings discussions, and it was something that stood out to me earlier on too. It's why are integrated CHCs, why are they better staffed by medical professionals like physicians, APCs, nurses?
Mhm.
Uh, Also, something that occurs to me as well, is there any sharing of staff amongst these? Is there anything like that going on, do you think, between
Yes,
like,
there's
yeah.
definitely that going on. So one of the interesting, like to one extreme, right? So there is one CHCs in California. I can't remember exact name of that, but that's the one that they are reporting basically zero staffing, right? But what happens is that they actually work with the health system, so they contracted all their visits to the physician group of that health system. Right. So they reported huge number of visits, but zero staffing. That's kind of one of the extreme example, but
Mhm,
by by extension, that happens, right? So they do have like shared staffing and using sorry, using the TMSIS data that actually we can identify people billing from multiple organizations. And we do see that quite often in terms of CHCs, but we don't really know if that's partially due to like sheer staffing or due to volunteers working like volunteer part of the time there. But we do know, like, what we can tell is that there are definitely quite a chunk of providers who bill from both a CHC organization as well as some non-CHC organization.
okay, that's interesting to me.
Yeah.
TMSIS. I'll have to remember that in the future.
Oh, maybe that's like I'm pronouncing it wrong.
Well, I
So
don't know either. We need an official person on here to let us know. But that said, you've already put a lot of work in this, you and your team. It took a large effort to bring all these data sets together, answer some of these questions. So I have to ask, do you have any future plans for research based on this?
Yes, we are eyeing for a R01 grant based on sort of this prior preliminary work we're doing here, and that's more about because this one like we kind of take some shortcuts to look at the aggregate CHC level results, but we want to be able to track individual patients to do more causal type of analysis to see what can or what's the impact of CHCs as well as integrated CHCs have over the Medicaid patients population. Yeah.
All right, well, thank you, Eric. And I don't really see any questions coming in here. Oh, hold it. All right. I stand corrected. Here's a question. Was there any collection on salaries for clinical providers? Did they increase with integration or affiliation? Interesting.
That's an interesting question. We don't really I think we can answer that question, but not necessarily in the current data sets. There is another data set called um sorry, I'm blacking out. The CMS collects the FQHC cost report. In those cost report, they actually have salary data and the FTE corresponding to those. So we can potentially, by looking at the timing of integration as well as integrated versus non-integrated, to answer this question. But we do have that's another data source we build over time is the from Section 3 to 30 grantees to their CCN number, which is a Medicare provider number. So we can take a look at that, but it's not currently analyzed. Yeah.
Oh, well, that was a really good question. Thank you.
Yeah.
Hey, we were just talking about future directions and research. There you go.
Yeah, that's actually very interesting because using TMSIS data, you can actually directly analyze the retention of providers because you can see that, from let's say 2018 to 2019, a provider is billing from a CHC and then they just fall off a cliff and go somewhere else in in 2020 or 2021. So that is actually I wouldn't say standard, but kind of very useful way to use claims data to analyze provider retention, just not only in CHCs but across the board. That's like a good way to use it. At least for billable provider, you can track their retention rates. Yeah,
Yeah, and that was like the comment, of course. This
exactly.
might be interesting to tie into the retention of providers, obviously, which
Yep.
you saw. Okay, let's. All right, we got another question too. Another interesting area would be TCOC by patient.
I'm not sure I understand that part. What's the
Yeah,
TCOC?
yeah, I'm not sure either. That's why I spelled it out. Could you elaborate a little bit?
Continuing the
And
continue
I'm
continue.
actually asking the individual who
I'm
asked.
just guessing that might be continuity of care, I guess.
Okay.
Yeah. Oh, total cost of care. Oh,
Okay.
that's actually unfortunately TMSIS data is very bad at that. So just a little bit reminder about like how Medicaid is organized, right? So most of them is actually organized in a managed care plan, right? So the managed care plan when they submit the claims, they do, like in TMSIS data, they don't have a cost component associated with that. So we cannot actually track the total cost of care. But on the flip side, if we kind of taking a little bit shortcut using, let's say, um, a certain part of that, if you can put a price tag on utilization, then you will be able to say something about the cost. But that part is like really a back on envelope calculation, right? You can do area level, like surgery cost or visiting cost, that kind of stuff. But you cannot really do like a visit by visit or service by service cost because that component is mostly missing in TMC data, unfortunately.
Hey, thank you, Eric. Oh, and this is something I often like to ask people towards the end of the webinars. What's your one take-home point that you'd like people to get out of this? If you had one thing for people to recall about this presentation, what would it be?
Don't get overly excited about vertical integration among CHCs because we don't really see, despite all the promises, we don't really see
Mhm.
that's realized in the data yet. Yeah.
Okay, well, yeah, hey, maybe the future will change things.
Mhm.
Well, if there's nothing else, I think we can end a little bit early. With that said, Eric, thank you. That's a very informed presentation. You and your team did a lot of work putting all that data together to get at these research questions. Thanks a lot for the hard work, and I'm sure others here appreciate it too. All right. Well, thank you, Eric, and
Thank
thank
you,
you, the
David.
audience.
Thank you, everyone.